Start with the chemistry, not the aisle claim. SAMe is S-adenosylmethionine, a methyl donor your cells already make from methionine and ADP. After it donates a methyl group, it becomes S-adenosylcysteine, or SAH. That SAM to SAH handoff sits inside one carbon metabolism, the same neighborhood as folate and B12. Marketing often sells one bottle for mood and joints. The molecule only promises methyl transfer. Whether capsules change depression scores or osteoarthritis pain is a separate clinical question that trials have to answer.
So when wellness videos call SAMe a life-changing nutrient for mood, panic, pain, and allergies in one breath, are they describing that methyl transfer, or just compressing every hopeful claim into one supplement story?
Picture SAM as a loaded methyl truck, and SAH as the empty truck after delivery. Cellular methylation supports pathways tied to neurotransmitters, membrane phospholipids, and hepatic detox chemistry. A higher SAM to SAH ratio can signal more favorable methylation potential on a lab panel. That is useful mechanistic language. It still is not the same thing as feeling less depressed, walking with less osteoarthritis pain, or safely replacing a medicine your clinician already prescribed.
Clinicians keep asking what the evidence actually says for depression. If someone has milder symptoms and hopes a supplement can stand in before an antidepressant, does SAMe clear that bar on its own?
Before we score the mood trials, remember SAMe does not sit alone. Folate, vitamin B12, choline, and betaine feed the same one-carbon neighborhood that regenerates methionine and influences SAM availability. A betaine aging review notes betaine can raise S-adenosylmethionine and lower homocysteine in discussed pathways. Placental methylation reviews link one-carbon moieties to site-specific DNA methylation patterns, with limited overlap across studies. Helpful context, still not a green light for every high-dose SAMe experiment. A 2024 systematic review of SAMe for central nervous system signs found benefit in 24 of 36, included studies covering mood, behavior, and sleep. Many patients improved on SAMe alone or with existing therapy, and adverse events were mostly mild, transient gastrointestinal complaints. That is a real signal in a messy literature. The same review still calls for better long-term CNS data, so treat it as encouragement with unfinished homework, not a blanket endorsement for every bottle on the shelf.
Then why did a 2025 mild depression meta-analysis report that S-adenosylmethionine did not beat placebo, even while other supplements in that same review sometimes did?
Because the mild depression review asked a tighter question. In that lane, S-adenosylmethionine did not produce significant improvements versus placebo. Other agents in the same paper, such as icosapentaenoic acid and rhodiola in single studies, did beat placebo. Population, comparator, and outcome choice can flip the headline. SAMe is not automatically the winning supplement for mild depression just because methyl biology sounds elegant. A different design looked better for a specific food supplement. A randomized crossover trial tested about 200 milligrams of SAMe daily plus Lactobacillus helveticus and Bifidobacterium longum against placebo for 3 months in subthreshold or mild to moderate depression. PHQ 9 and HAM-D scores fell more on the active combination. Useful for that product and population, especially when someone is not a good antidepressant candidate. It does not let every high-dose SAMe bottle borrow the result.
A lot of supplement talk still pushes SAMe for osteoarthritis pain and even allergies. Does this research packet actually put joint outcomes on equal footing with the mood and liver papers, or is that mostly marketing echo?
Liver is the clearer second clinical lane here. A 2024 systematic review of SAMe for liver health found improvements in liver-related parameters across mostly high-quality included studies, commonly using about 1,000 to 1,200 milligrams per day, sometimes with another therapy. Adverse events were again mostly mild gut complaints. Better labs are meaningful, but they are not a promise that SAMe cures every chronic liver disease or replaces specialty care.
Online, People also worry that stacking SAMe with antidepressants could tip into serotonin syndrome. Is that a real clinician boundary for this supplement, or mostly internet fear layered onto methyl donor biology?
While we are separating signals, keep biomarkers honest too. A 2025 randomized trial lowered plasma SAH by about 12% and raised the SAM to SH ratio by about 26% over 12 weeks. But the test product was ashwagandha extract, alpha-GPC, and creatine, not SAMe capsules. Folate work in children with sickle cell disease also shows 1-carbon metabolites can shift when clinical pain outcomes do not clearly move. Marker change is a lead. Symptoms are the verdict. Treat the interaction problem as real enough to plan around. NIH complementary health guidance is direct. Dietary supplements can interact with medications and can pose risks with certain medical problems or before surgery. For SAMe, that means a clinician should review SSRIs, SNRIs, MAOIs, other serotonergic agents, and peri-procedure timing before anyone experiments. Supplement aisle convenience is not a medication reconciliation, and store products can differ from the formulas used in trials.
If someone and their clinician still decide on a time-limited trial, what should they actually track so they're not just chasing a prettier SAM to SAH ratio while symptoms stay the same?
2 more boundaries sit beside any trial plan. Mood-active methyl donors can unmask mania or hypomania in susceptible people, so bipolar spectrum history is not a casual detail. Pregnancy, breastfeeding, and significant disease also change the risk math. Under ordinary U.S. dietary supplement framing, products are not pre-approved like drugs. Retail SAMe can differ from study products in dose, salt form, coating, and stability. Enteric-coated research SAMe is not guaranteed by every bargain bottle. Predefine the target that justified the bottle. PHQ, 9 or HAM-D-style mood scores, sleep, function, or liver labs if liver was the reason. Give it a clinician-agreed window measured in weeks, not overnight miracles. Compare against the standard care already indicated for that person. If scores do not move, gut side effects dominate, activation feels too high, or medicines collide, stop and reassess. SAMe is a biologically plausible methyl donor tool with mixed clinical evidence, not a universal mood and joint fix.